Okay, so I will be presenting artificial intelligence and diabetic retinopathy. I will be just giving an overview of what are the things and how we should analyze this thing, because a lot of us have a lot of circumspect on this AI thing. We all know that the incidence and prevalence of diabetes mellitus is increasing, and India is the established diabetes capital of the world. Early detection, so AI becomes very important for a country like India. Early detection and treatment of DR is the one of the main armamentarium to remain, and it is one of the priority for preventing diabetes associated sight loss worldwide. Now, the current models are based on mainly human grading as we have in India. It is what are the cons in it? This is a labor intensive process. It requires trained human graders who should be trained to undergo also regularly quality assurance and be retained. So retaining the staff is also a big challenge in India. And the scalability is a major issue because of the human manpower installed in this. And there is a recurring high cost of manpower. And obviously we have fixed working hours. So if we apply the current UK annual screening protocol to in globally, we would require at least 2.2 billion retinal images to be screened or graded in 2030. So here comes the role of AI. In the last decade, large strides have been made in developing automated retinal analysis, imaging analysis systems, some designed specifically to detect DR. These rely on different image analysis methods, generally based either on human designed lesion detection algorithms or machine learning, or a mixture of these two broad approaches. What are the advantages? They do not get tired and grade thousands of images a day and often able to provide results within seconds to minutes of taking the photo. So you can install it in a village setup and you can get the results regarding the trials and the risk factor. The scaling of automatic DR screening programs are furthermore largely just a matter of accuracy. So mainly money is the constraint, not the human manpower. One important thing in diabetic retinopathy screening is actually already primed for telemedicine. Diagnosis of diabetic retinopathy is only contingent on the use of a single modality image, that is a color fundus photograph, if we are able to acquire it. And it is determined by classic morphological features in the retina, that is microenzymes, hard indurates, vitreous emerald, without the need for additional clinical data input, making diabetic retinopathy screening highly amenable to teleophthalmology as a digital service to decentralized care. What we are currently giving in India is centralized care, that we just good care in the cities or district level. So we have to actually decentralize this care. The use of artificial intelligence for diabetic retinopathy screening is based on several key factors underlying its relative success. So there is already a synergy between two digital innovations. One is the telemedicine and artificial intelligence for diabetic retinopathy screening. And there is obviously a clear public healthcare need for diabetic retinopathy screening that cannot be met with current models of care. And we should see AI as an incremental technology and not as a disruptive technology. With foundation in teleophthalmology already established, artificial intelligence solutions are easier to incorporate in the diabetic retinopathy screening programs. And it should be considered as an incremental technology to teleophthalmology, and existing shortages and the required resources to cater to the growing burden of diabetes medical patients create the clear need to implement artificial intelligence-based solutions to increase the capacity of DRS screening. So this in teleophthalmology, we are basically taking a photograph and we are allowing a grader to grade the image. So it has its own limitation, but what if we combine teleophthalmology with AI, we can actually make the system more robust and more AI. Now, whenever we are developing a framework for an opportunities for AI, we have to gradify it also. Like we can use an AI for DR screening. And once we have passed this screening and we have tried that, okay, these are the patients which are at risk, then we can develop another AI for DR prediction. So this is another model. And once we have established case, we are likely to establish another AI for DR and DME. So it should be a stratification level. The current prevailing systems, there are a lot of automatic DR detection of DR at various places in the world. As we have seen in the last slide, in 2018, US FDA approved the first AI-based DR detection system in USA. Now, there is a very important thing. There are multiple systems that are available in the world, but what we have to look is the sensitivity and the specificity, because with lower sensitivity, more cases of DR are missed, which goes against the main aim of a DR screening program, the early detection. And with lower specificity, a relatively large numbers of false positives that warrant further examination are returned, which wastes the resource that automated DR screening is trying to spare. However, with the newer deep learning system, as we have discussed in the previous stocks offers the promises of an impressively high sensitivity and specificity. So we can see from 2015, which is the first IART was introduced, and it had a sensitivity and specificity of around 91%. And then there are multiple systems which are already in progress, and these are the techniques these algorithms are using. Now, one of the limitations of developing an AI system is a large set of retinal images on which to train and validate these algorithms is the biggest hurdle to development of an AI system. The major issue is the confidentiality, data protection, and country-specific regulations. Image data set need to be human grade and labeled as a reference standard. And the publicly available Macedon-2 dataset contains over 1700 labeled retinal images has been used to validate and compare some of the study. However, now what is important is very important. However, this dataset contains images of excellent quality of a level that is not representative of real life screening applications. And developing deep learning systems against human grading. So you are basically, if you are, once you understand the deep learning system, and then you give a parameter of human grading as a gold standard limit, this potentially, limits the system limit only. So automatic retinal images might surpass that of human graders in the future. This is, however, not quantifiable if human grading is taken as the objective truth. So the image that you are using to train, they might itself be a barrier to the deep learning system. Rather than what many persons are advocating is that a patient outcome-based truth rather than clinician agreement to validate such AI systems have shown that it performs better than human graders. Now, evolution of artificial intelligence has been a long time. In 1950s, John McCarthy first used the phrase of AI, and a major progress is the shift of traditional pattern recognition techniques to the near and exciting deep learning system, which we already have discussed in the past. Now, diabetic mellitus is what is the advantage of deep learning? The diabetic mellitus is a multifactorial complex disease. Our existing methods for predicting the development of diabetic retinopathy are imperfect, whereby glycemic exposure, that is glycated hemoglobin, and duration of diabetes only explains approximately 11% in variation of the risk of developing diabetic retinopathy, as was reported in the DCCT trial. However, unsupervised learning of deep learning algorithms enables them to self-learn predictive features from input data for labeled outcome without being explicitly programmed to detect specific morphological features by the expert. Therefore, their predictive capabilities are not restricted by our current existing knowledge of disease phenotypes and risk factors. What deep learning can give us an advantage in DME management. We all know that variable treatments response to treatment modalities occurs during anti-VEGF therapy, but we still don't have any concurrent answer why it is happening. A recent pilot study has revealed that deep learning could be used to effectively predict patients with DME that are more likely to respond to anti-VEGF based on pre-treatment OCT imaging scans. So, deep learning can shed light on phenotypic variations, clinical factors that contribute to variation in outcomes, and a new era of personalized management service is in the horizon. Why do I tell so? How many of the ophthalmologists can tell from the photo below if the patient is a male or female? It's a 50-50 chance. However, for Google's deep learning AI, it's almost 99% chance. With the advent of COVID-19, the AI has become more pertinent. Ophthalmologists and other eye care professionals are at high risk of community transmission during patient evaluation. AI coupled with teleophthalmology is well positioned to facilitate continuity of decentralized care for diabetes mellitus and diabetic retinopathy patient during COVID-19 pandemic. And in fact, COVID-19 may be a catalyst for realizing the value of artificial intelligence and digital health technologies that have long been neglected as a result of various barriers to adoptions. Now, we all know that everything it works on an economics. So if we add on a lifetime basis of how much economic burden a country has to face, it's almost 20 to 40% saving that is being given by if we incorporate AI into our screening programs. However, there are barriers to AI adoption, and mainly it is the cost of the automated system, equipment, hardware, trained technical staff to operate the equipment, secretarial staff, and current commercially available systems still require trained human grader verification, especially with the relatively low specificity of most systems. One of the major concerns is AI a concern for ophthalmologists? Unlikely that we'll see wholly automated DR screening system any time soon. Human graders will still be needed to judge atypical or low quality images as well as for quality monitoring. Increased detection of patients requiring tertiary care will increment our practice and not decrease it. And deep learning can demystify many concerns in risk stratification and DR management, along with development of a new era of personalized level of medicine. In the end, will have to embrace AI and together we will rise.